This
Anyone
conference
wanna,
will now be recorded.
does anybody want to chime in and give us some information on what the barriers might be? It's really meant to be an open conversation, and we're just trying to figure out, or are the coordinators not aware that that is the request of the DCC?
Some of us had a
This is Jen
hesitation.
from Cincinnati. We have some in there. We've put a whole bunch in, and then what we've learned is that they've transferred care to another institution. Is there a way to get them out of the screening? So we're putting them in. We're getting
Mm-hmm.
lots of them enrolled, but I want to pull some out. Is that allowed? Thank you.
That, thank you for speaking up, because we can't impact change if people don't speak up as to what the barriers are. So that that question I can't answer, but because I actually don't go into PSC link. The PIs don't go into, yeah, go ahead.
These are people you've enrolled in the study and then they're transferring?
No, screening,
Care?
right?
No, they're not enrolled.
They're
We
screened.
screened them, and then they there was a note in the chart, or they didn't come back, and they transferred to care before we had a chance to approach them.
Okay, then I think you just put not approached and you don't need to pull them out. You screened them, so that's, but then you're not going to approach them for the study.
Wouldn't that affect wasn't part of the concern was to see why they weren't enrolled? And if we just put they weren't approached, wouldn't that imply?
I believe there's also a reason that they're not approached that you can complete.
Yes, so on the consent form, so what you're going to do for those participants is go into the consent form, and A1 asks, was the patient guardian approached for consent? And if you answered no, then if not approached, indicate the reason why, and you select all that apply. Demonstrated past noncompliance or non-adherence to medical visits or therapy, barriers to obtaining informed consent, like dementia, language, or other, not approached per treating physician or other. So this is where you would put, you would check other and then put transfer to another site. And then that should be all you need to do. And that will show in your census column then as not consented.
That makes sense. Thanks, Terry.
Sure.
I feel like one benefit to adding someone to the screening log is at the time of the enrollment, if you have a chance to do the fiber scan, you already have a subject ID number that you could input into the fiber scan machine.
That's a good point, Erin. That's what, I was thinking of the same thing that, once, if you put that information, then the number is already assigned to that person. So you just got to make sure you keep track of, if you do that, who is assigned that participant ID. But you got a good point, because everything would be there. You just have to put in the consent information then. Thank you, Erin and Jen.
I'd love to hear from some of the institutions that haven't been putting in screening information ahead of time. And a couple of things we're thinking are, one, are you not getting the communication from the PIs as to who the potential patients are, or do you just not have enough time? We really are trying to figure this out because it hasn't really improved much, with the exception of 2 or 3 institutions.
I can share. This is Mo from Philadelphia. So Kathy has like an entire list of where she has the people whose criteria she's reviewed. She does like a very good job. She communicates with us very, very clearly. Then the barrier at our side is that IRB is pretty strict. So they actually don't allow us to enter in inclusion or exclusion criteria from people who haven't officially signed a consent form. So usually what we do is we will like approach the patient, and then if they do consent to take part in the study, we then enter them into PSC link after the fact and say that they did consent. But we haven't been entering the criteria from people who we determine are like not eligible, just because IRB doesn't really allow us to do that. So that's all we haven't been doing it.
Ah, okay.
Mm-hmm.
So if you can put it in if they're potentially eligible, but they haven't signed consent. You can put it in, or you can't put it in on anybody if they
We can
haven't
only put it
signed.
in for the people, yeah, who've signed consent. That's the only time we can do it. If they sign consent, then agree to take part in the study, we can then put it in. But for those who haven't been consented, like who haven't consented to take part in the study officially, we can't put it in
So
at all.
you're basically saying you can't put in screening information because your IRB does not allow you to do that without a signed consent.
Yes, exactly. Mhm.
All right, we got to bring that one back to the to the DCC leadership.
Mhm.
Okay. Any other barriers to people for the institutions that haven't been putting screening in? And I specifically would like to hear if your PIs just aren't providing that information, because that's something that we can impact and bring back to the PIs. We're not going to point fingers at a specific PI or a specific institution, but just we're trying to get general themes here.
Hi, Cara.
Kara,
So at University of Utah, we have a list, and we're doing this all on the back end, but
Yeah.
we feel uncomfortable with entering in the birth date of someone who has not consented. So we have a similar issue with that other site where it's asking for
So
PHI,
we've been
but they're
through
not.
this, Natalie, we've been through this a whole bunch of times with the coordinators. If you can't put in the whole birth date, that's fine. Put in just the month and year or just the year as directed by your IRB. But we're not asking for the full birth date for anyone who's not consented. And we've reiterated this a bunch of times.
Right. So you can see that we just put in our small duck screenings for PSC, but we've left out full dates. It's not just birth date, but any full date for a patient's medical record is considered PHI. But we put it in with just years.
That's fine.
Kara, this
Okay.
is Jen again. I think one of the other, we would have a whole lot more screenings on our list if the radiologist didn't have to sign off on it first. Like when we go
Right.
into link, the first thing that we're asked is, is it small duct or large duct and who signed off on it? Like
Right.
those questions. If they
Right.
switched it to the exclusion questions first, because like I had one kiddo that was transplanted. And my radiologist didn't want to look at the MRCP if the kid's transplanted and he's not going to be enrolled, which makes perfect sense. They don't have time to do that. So if the exclusion criteria was first, I would have hit, if the child was transplanted, the MRCP never has to be read. But you're getting information, you're getting why they're excluded. They're excluded because they're transplanted.
Yeah, I can tell you that most PIs aren't even putting a transplanted PSC patient on their list because that's not who we're studying, So I think that's a rare event that you're describing.
Or any of the other exclusion criteria. Like if we exclude them, if they hit one of the 20, then there's no need to do the MRCP review or the histological review at all.
Yeah, I'm not sure. I would.
Cara, do you want those captured? If we know right offhand that they already meet an exclusion criteria, we wouldn't bother sending them to our radiologist. But do you want that captured in children? Is that even an ask?
I think that most PIs knew what the inclusion-exclusion criteria were when they were looking through their PSC list. And if it was an obvious exclusion criteria, for better or for worse, I don't even think the coordinators would be aware of those patients because most PIs knew that they wouldn't qualify, that patient wouldn't qualify. So if,
From the coordinator's end, if they review the inclusion exclusion with their physicians first, and then from that batch go to the pathologist or the radiologist, those are the ones that are put in for screening.
Yeah, I think that's the way most of the PIs were thinking about this. we all knew what the exclusion criteria was, such as transplant, and therefore that patient wouldn't have gone on our preliminary list of possible patients. Now that may have been an error, but I think that's what most of us did. So Charlotte or Terry, I don't know if you guys have anything else to add to this part. I think in most cases, over 90–95% of the time, you're not going to have somebody with an exclusion criteria. The things in that exclusion criteria apart from transplant are pretty rare. But so I don't know if we can really switch the PSC link format like you're requesting. That's
yeah, I don't think we're gonna be able to change the way link is set up, but I think that you can go in and not fill out the inclusion criteria, but still fill out the exclusion criteria. So if you knew that somebody had a transplant, if you looked at them and you said this person has a transplant, I think you can go in and just click the transplant and close it, right? And at least we know then that you looked at that person and we know why you excluded them.
But that's the question. Is that an ask that you guys want everyone listed, even people that were excluded right off the bat because our physician knew that they had been transferred with her?
I think we do. Anybody that you looked at, we want to be in the screening log. And that's to make a diagram that we would use at the beginning of a paper where we would say, we looked at all the PSC participants and X many of them were excluded because of various exclusion criteria. So I think if you look at them, then yes, we want them on the spreadsheet.
Yeah, and I
sorry,
think
not the spreadsheet, in link.
Right, in link, and
but if you don't have the radiology information, you don't have to put in the radiology information. You can just put in that you excluded them and what reason you excluded them for.
Yeah. So I think that, Charlotte, is that's going to be more PI work, which we'll have to see at the face-to-face meeting if they're willing to do that, because I think a lot of PIs perused their list, knowing what the exclusion criteria was, and not even telling the coordinators about those that didn't meet criteria. So that's going to require more work on the PI. So we'll discuss it at the meeting. Charlotte, can I ask, are you or Terry taking notes on this talk today? Otherwise, I got to grab a pen.
No, it's being recorded, Tara.
Let me grab a pen.
So we're recording. Can you hear me?
Yeah.
We're recording the call. And so what we'll do is we'll put the recording and the slides up on the website.
On the website. So I'll use that.
Yep. Yeah, I'm the one that's doing the minutes, so I'll just go through the recording and get everything out. So no worries.
That's great. Perfect. So I'll just take notes from the recording. Okay. Why don't we go on to the next? And I think the next, well, this is just something else that, again, Cincinnati did, was they sent an email to families. So they must have a way to have emails on all the PSC families, letting them know about the study ahead of time, and that the families appreciated that they had a heads up. When I was in Colorado, I called some families and just let them know. They were families that were very interested in research in general. And so I'd call them and let them know that this study was approved and an overview of what it was. And so that's something we can bring it up again with the PIs, but something to talk with your site PI about is there a way to let these families know about the study ahead of time? And if they seem interested, then you can be ready to get them enrolled. And there may be institutions that can't do this. So, but Cincinnati could, and Colorado could as well.
So Carl, I think physicians that actually are in charge of some of these PSC patients can reach out.
Yeah, and that's what
yes,
that's what we did. Yeah,
right. That'll work.
So, yeah, but I think it has to come from the PI as compared to the coordinator. Okay,
No,
next.
that's correct.
Yeah.
They can just remind the patient that this is the number of the physician or the study coordinator that you should contact if you're interested. If it's not, the same person making the contact with the patient.
Mm-hmm. Yeah. Okay, next slide. And then you can go to the next. This is more specifics on the PSC link. And you guys already know this. You can keep going. This was some information we gave last year. And we went through eligibility. Let's see here. I have gotten a few questions about, the patient is 18 and after, another year or so, they're going to transition to the adult. Should we enroll them? The answer is yes. Even if we only get a baseline visit or a baseline and a 1-year follow-up visit, that's really great information, especially the baseline visit, because we're getting so much data at the baseline visit that in that snapshot, that point in time, we plan on doing a lot of statistical analysis related to, for example, what the FibroScan showed versus a serum biomarker. Do you have a biomarker that predicts fibrosis? Those types of questions can be answered based on the snapshot that we're going to get with these baseline visits. So that's bullet point number 1. And then again, small duct only PSC, you have to have an MRCP that is normal and an abnormal liver biopsy for that diagnosis. Large duct disease, we've gotten some questions in the past year. Can you use a CT scan or an MR enterography to diagnose PSC? And we checked with the radiology corps, and the answer is no. You have to have an MRCP or an ERCP to diagnose large duct PSC. And then I think many of you have been through this last item where you cannot get the images at the time of diagnosis of PSC, that MRCP. It was done outside your institution and you cannot get the images, and the question always comes up, can you use the report only? And that answer is no. Your site radiologist has to review the images. Some people have gotten around that by redoing the MRCP. Like, let's say you met somebody who had been given a diagnosis of PSC 5 years earlier from somewhere else. Now they're coming to see you clinically. The physicians have been getting a fresh MRCP because it's part of clinical care to know really where they're at with their disease, and then use that one for enrollment criteria. Next slide. And please interrupt if you guys have questions. So now we're just going to talk about the baseline visit. Next slide. There's many different scenarios for how you can get all of that work done related to the baseline visit. The first scenario has worked well for patients that are outside of the city or the area that your institution is in, where you contact them ahead of time. They say by phone, oh yeah, absolutely, I've been waiting for a study like this. And you go ahead and get everything set up, including the MRI studies, so that it's a one-stop shop with that baseline visit. You get everything done, their clinical visit as well as research. But then there's other varieties as shown here, how to get things done. And a lot of people get most of the studies done with the exception of the MRI studies, and then they have them come back for that one for a second visit. Any questions about that?
Hi, Cara. It's Siri from LA.
Yeah.
I do have a question. I actually have a patient in-house right now who we screened for the PSC study, and it looks like we can enroll. However,
Yeah.
I know that we have to complete the MRCP, to submit with the study itself. The subject underwent, let me see here, the ERCP back in 2014, and I emailed the radiologist. I'm pending for the confirmation from our radiologist. I think my question to that is, if they are in-house, obviously the visits are going to be a little bit different than, just having them coming in clinic. Actually, I don't really know what my question is. I just wanted to
Well,
let you know
you
that.
can- Yeah, I mean, you're trying to get the ERCP images to confirm the disease.
Correct.
You could also get a fresh MRCP. It's been 9 years since that
Right.
diagnosis. Most people within 5, maximum 10 years are redoing an MRCP to see what's going on. So that's option 2 if you can't get the ERCP. But DCC, correct me if I'm wrong, I don't think there's any reason why you can't consent while they're inpatient. I don't think there's any, assuming you confirm eligibility, if they're still in-house inpatient, I don't know why you can't consent.
Okay,
No, you
yeah,
can consent to, yeah, because that would be just like those, the pearl babies that are admitted
got
to
it.
the hospital. Yes,
Yeah,
it's the exact same kind of situation.
Okay,
yeah,
perfect. Okay,
yeah.
perfect. Yeah, I just want to confirm.
Yeah. What you can't do is use the research MRCP as a clinical MRCP.
Right.
Right.
Correct.
Because I've
Correct.
gotten that question as well. So unfortunately you can't. But here's the other thing. Only 300 of the close to 800 kids we hope to enroll, only 330 will have an MRCP. So research MR studies. So if they do have to get a clinical one, they don't need, they can be part of the trial and say that they don't want the MR component of it. And that's okay. We're
Okay.
totally fine with that because it is a hardship in many different scenarios to get the MR studies done.
Right, right. Okay, awesome. Thank you so much.
Yeah.
Dr. Mack,
Oh,
this is Laurel from Houston.
yes.
Do you know if anyone has had success combining the research MRCP and a standard of care MRCP so that the patient just has one exam
Yeah.
but with 2 components?
I think that Cincinnati has tried that once. It's a long time in the MRI, but theoretically you could do it, right? It's
Okay.
no radiation.
Yeah. If there are
Yeah.
any coordinators who have done that, I would love to hear from them. So if you're a site that's done that,
Yeah. We, for a while,
speak up
we
or
took
reach out to me.
Yeah, we had this retest variability where we were going to look at like 20. Do you remember that, Terry? We were going to look at like 20 kids, put them
Yep.
in the MRCP machine, take them out, put them back in, and then look for differences in readout between those two. And so, so theoretically, you can do it. Go from one MRCP to the next. So if that works for family and their game, I don't have an issue with that. We can double check with radiology core, but
Oh,
it
hi.
seems reasonable.
This is Allison from Houston. Can I actually have a question about this? Because our patient, we actually have 2 patients so far that they have need both the research MRI, the MRCP, the research MRCP, and the clinical MRCP. And the original plan was to get them both in at the same time, but that's like a really long time laying down in an MRI machine. So what we're trying to ask is to see if we can combine the research one and the clinical one, which means, we do the sequence for the research, for the clinical MRCP, and then we add on the research component of it. Is that something that is
Those
allowed?
would be 2 separate MRCPs. No, that's what I said earlier. They have to be 2 completely separate MRCPs that are not combined in any way. Your clinical MRCP, 100% of that has to be separate from the research MRCP, because the research MRCP is a regular MRCP, plus it's a MRCP plus is the abbreviation for it, the perspectum images, and it's an MR elastography. So it's a whole different sequence compared to a clinical, or additional sequences compared to clinical.
Okay,
So you
thank
can't
you.
combine the two.
Thank you,
Yeah.
Stephanie.
Yeah.
Mara, do you know if they are doing a clinical one at the same time as the research one and the clinical one requires contrast? Will that cause a problem for the research one?
That's a good question for radiology. It's a great question. So I'll, in preparation for next month, I'll ask that to the radiology core. It's a great question.
Okay. We had one of those in December that ultimately declined the study, but we were worried about whether they would conflict
Sure,
anyway.
because clinical MRCPs usually use EOVIST, right? That's correct. And our research MRCP does not use contrast. Yep.
Yeah. Okay. Thank you.
Yeah. All right. Should we go on to the next, or? This is just a snapshot for everyone of the visits and the associated CRFs. And I will, in the next few slides, highlight some of the issues regarding that initial history CRF, the lab CRF, and then let's see, these others, the IBD activity, liver stiffness, and MRI visits. Those are just, yeah, I don't know that I'll say a lot about those, but I did just want to provide this snapshot for you guys so you can see, again, how I mentioned the majority of the data is happening at that baseline visit, and then annually, with the exception of the MRI will just be year 1 and year 5 in that subset of patients that have a baseline one. Okay, next slide. So these are subcategories within that initial history CRF, and that initial history CRF takes a while to complete, especially if you have to go digging through other institutions' charts regarding IBD at diagnosis and labs at diagnosis of PSC, for example. So this really, if the coordinators, guys should not feel that you have to complete this all by yourself. There are so many nuances and medical terminology to the IBD specifically that the most efficient way to get these completed, especially parts B, especially part B with the IBD, is with your PI. And the PIs know this. We've been saying this since day one. Next slide. So this is just an example of that IBD at diagnosis within the initial history CRF, that it does ask for a physician global assessment at the time of IBD activity. In order to really accurately assess that, you have to go in and try and find the PUCI score or significant description from the physician that was seeing the child at the time of diagnosis. So this is just an example of something that most coordinators are, unless you did a lot of IBD research, you're not comfortable doing. So that's just an example of where you have every right and you should reach out to the PI for guidance on that. And then another example is in B14 to 19, where you actually have to find the procedure note at the time of diagnosis of IBD. So any comments on the initial history CRF? In general, are the PIs helping you guys with that?
Yes.
Yeah, good. Yeah, okay, next slide. This is just another example. One thing I do want to point out that you can kind of do a check with your PI is that we're trying to get a snapshot of what those kids look like at the time of PSC diagnosis. So their diagnosis date is the date of their MRCP or their liver biopsy that diagnosed the disease. So then you want to try and get what their labs looked like at the time of diagnosis. And what happens sometimes is kids get placed on ursodiol or vancomycin after the diagnosis, and a month later, their labs are better. So try and get labs as close to the time of diagnosis, but if you had to choose a time point, you would want a few days before or around the diagnosis or day of diagnosis as compared to a month later, just because if they gave them medicines, it could skew the results. It's not a perfect science. This one is not perfect, but we just wanted you to understand kind of the timing of the labs at PSC diagnosis. And if you have a choice, 1 week prior to the diagnosis or a few days or a week or two after, probably choose the 1 week prior, but you can double check with your PI. Okay. And then this is just another reminder that the majority of labs that are obtained at every single visit, including the baseline research visit, the majority of those labs are considered standard of care clinical labs. And what we found is that many of these labs are missing in the baseline visit CRF. And so I think that Terry, correct me if I'm wrong, that 1 month window, are we expanding that for the baseline labs?
It was, yes, for baseline,
It's going to be
6 months and 1 year, I believe it was.
I think, but my window will be 3 months now for baseline.
Yes, yep.
Yeah, so that your window would be 3 months, you guys, and that just happened a few months ago. And that is so that we can capture more of these clinical labs. So that can include a little chart review if they're coming for their baseline visit, and let's say they had clinical labs 6 weeks prior, you can use those. If the attending is not planning on getting another set of labs for the research baseline visit, if they're not getting clinical labs, you can use the labs now from 6 weeks prior, for example. Okay. And the only research labs are the bottom ones, the total IgG and then the autoantibodies. And those are being obtained at baseline. And if for some reason they're not done at baseline, they'll be done at a follow-up visit, but we're not going to recurrently be doing those. We just want to obtain one set of it, preferably at baseline. Any questions on the labs? Okay. We can go to the next slide. And then the biospecimens, we have about 70% of those enrolled. We have serum and plasma. I think DNA is about 60%, and PBMCs are close to 70%, 60 to 70%, I think, for all this. So that's good. We would like it higher. And so I did want to pause and ask, are you guys, is there a difficulty in getting all of these biospecimens for research? Because it is a lot. I mean, I saw when I was in Colorado, Cynthia had half a dozen vials, right, for all these different things.
Carl, this is Jen from Cincinnati. We have 4 of our 15 enrollees that repeatedly come on a Friday, and I kid you not.
Oh, yeah. So the Friday means you can't get the PBMCs because you have to skip them. Yeah. And that is what it is. I mean, that's, there's limitations to this study, and that's a core that's not going to accept a sample on a Saturday. So that's, that there's nothing you can do about that. You want them in the study. So if all they want to do is Fridays, that's all you can do. Yeah. Okay, we can go to the next slide if there's no questions on this. And then, yeah, here's something I did want to ask you guys about the stool. Now, the stool kit is given to them at baseline. Most of the time, it's my understanding they take that home. They're supposed to add their stool to it and send it off. It comes with an envelope to to send off. I think it's a FedEx envelope. And is there any checklist where the coordinators are following up with the families to see if they submitted it? Or are we just waiting to see if the microbiome core, once they receive it, then yes, eventually that information gets to the DCC. But
I know there are some sites that are watching their, see, Deepika from Toronto, she actually will make phone calls. And then see Moto from Philly will follow up with phone calls or email. So the coordinators are tracking
are they?
to make sure that
Yeah.
get the certificates in. Mm-hmm.
Because I think this was the lowest collection rate. I think this was like only 40% or so was actually received in the microbiome facility. So if the coordinators,
I do know, Cara, too, that some of the stool kits are they miss getting distributed at baseline. So there's distributed or sent out. I know Cincinnati does send out the stool kits to participants and families. They do send those out.
Mm-hmm.
So there's a different.
Okay. Yeah, that's all right too. Yeah.
Text reminders, follow up. Oh, see, and then Deepika says that the families actually notify them when they send the sample to the facility. So that's a good thing.
Mm-hmm. Mm-hmm.
We're having similar experiences to that Deepika's having. We send them home with this toolkit and we follow up if we haven't gotten a notification that we check their FedEx because we put the pack together for them and we know the FedEx tracking number, so we check it to see if it's gone out. And if it hasn't, we follow up with them. And we have one patient in particular who just is horrified by the idea of doing it, and we reminded her and she's just really unimpressed with the idea. So for the most part it's worked, but some patients, you ask a teenager about poop and some of the girls, or especially girls, are just not in.
Right. So. Yeah. No, we understand that. So that's great that some of you guys are doing that. And so we can bring this up to at the meeting next month. Do we want to try and implement that for every institution, some type of follow-up? Because I think it probably makes a difference. A quick phone call or text to the family saying, hey, friendly reminder. Yeah.
Definitely. And for our 1-year follow-up, we're going, if they're doing the MRI, we're hopefully going to use that $50 gift card as a little bit more leverage. Like, hey, I really need you to get that stool sample done before I can give you this $50 gift card. So hopefully a little bit more of a carrot will do the trick, but we'll see.
All right. I don't know if that one's legal, but we'll see. Yeah. Okay, next. Should we go to the next slide? I think this is just at the baseline visit. The IBD activity is you may need help from the PI unless they have taught you how to calculate the PUCI. It's not that difficult, but next slide. And then the imaging, just as I mentioned earlier, we're only getting imaging MRs on 330 of the anticipated 750 to 800 kids. And so if it's really a hardship, you guys, it's just not going to work. It's okay. Still enroll them in the study. They're just not going to be an MR participant. Fiber scans, we want at baseline and annually thereafter. Fiber scans in the adult world, they are NPO. And so we thought since a lot of our kids are teenagers, they should be NPO, and it's at least 3 hours, 3 or more hours. So 2 scenarios with that fiber scan. Often they're getting a few scenarios actually. They know ahead of time they're doing the study, so you can remind them if they want to get the fiber scan done in clinic, not to eat breakfast until fiber scan's done. Or kids often skip breakfast, so you're able to do that fiber scan in clinic, or you plan on doing the fiber scan on the same day that you're getting the MRI studies, since you have to be NPO for that. So there's different ways of getting this done. I think that well, I'd like to hear when are the fiber scans being done? Are you guys getting them mainly in clinic or yeah?
This is Anne. I'll offer some thoughts.
Yeah.
For all of our first 9, we did them as, well, except one, we did them as combined visits where they came in, they saw us, they saw Dr. Deneau, they did the fiber scan and the questionnaires, and then we walked them over to MRI. So we did them all in one big full visit. Something I found is super helpful and has made a difference actually is that the fasting, obviously the 3 and the 4 hours can be combined into the same fasting coming for the same visit. I have called or connected with parents the day of, usually right before the fasting is supposed to start, and they go, oh yeah, oh crap, and then they start texting their kid at school to tell them not to eat lunch because they're going to be at our clinic at 3 and they need to have been fasting. And we've caught 2 now right before lunchtime to remind them not to eat, or the whole thing would have been a bust. So
Yeah.
the reminder that the morning of has helped a lot for the fasting.
Okay. All right, thanks. Next slide. Yeah, so the fiber scan. I know that most institutions are still using the older fiber scan machines, but if you have the newer one, the 530 or 630, it's recommended just turn off this smart exam option, so it's compatible with the older versions. But I did want to ask, are people still having trouble getting the fiber scan reports uploaded into the FORCE portal? And I know the answer because I've seen the data, but I would like to hear why. I know that fiber scans are being done on these patients, but at the DCC end, they're not being seen as uploaded on the portal. So what do coordinators, what are the barriers to that happening?
This is Cynthia in Colorado. I've had issues with low disk space on the USB port, flash drive recently, and so I've been having issues with getting a new USB for the FiberScan machine itself to be able to upload. So that's my issue currently.
And so that would need to be provided by the division or for research? Can the DCC weigh in on the problem?
Well, that would have to probably come from the PI at the site. I don't understand if you need a USB port, it's going to have to be big enough for the images. So that would have to be something that's going to have to come from your site. So you should talk to.
I've ordered a USB, but it was the wrong one. It was incompatible with the machine. So right now I'm trying to get one that is compatible for the FiberScan machine because the one that was provided was not compatible.
I see. And so are you talking to the company or your PI or Ron? How are you actually helping get it done?
Through my manager. And yes, I've tried to call the person here, Carla, who would use the FiberScan machine a lot. I've consulted with her, and she said just getting new USB drives, it should be fine. But the challenge has been just getting that specific one. I don't know if I should be reaching out to the
PI.
whoever the manufacturer is. The PI knows. Dr. Sundram knows.
The PI knows what's going on. Yeah. Okay. Yeah, I would also, and the PI, Shika, could also reach out to the company because they may be able to quickly tell you, here's the one we recommend, here's where you can get it. Because it sounds like
I might do next because it's been a challenge here at the Institute.
Yeah, okay. And then what about others? Because there's quite a few institutions that are missing FiberScan data. And we're hopeful that you actually have it. It just hasn't been uploaded yet.
So
sorry. We can go, Terry. Sorry.
Go ahead, Moto. Moto, go ahead.
And I was going to say that, yeah, we had to reach out to Terry and then also Melissa about this a few times. The data was showing up as 0% completion. I think apparently we're using like the new machines. I think she mentioned that maybe it could be like coded differently, like the file. Then also we had to use the Excel probe for a few of the subjects. So I think, but now hopefully I think we should be fine though, Terry, or should I upload it again?
No, I think so. I haven't seen anything come across, Moto, but that is true. So that is why we keep telling you that if you use it in a new machine, you need to let us know, because the coding is different on the older machines than it is on the new machines when the scans are uploaded. So the person who downloads the machine doesn't know that, so they kind of like miss them. And also, it's the naming convention. We're able to catch the naming convention and ask the sites to re-upload it, but you really need to make sure you're following the naming convention. And I think we had a couple of cases where the numbers were transposed or something, and then of course that participant wasn't found at your site. So you really need to make sure you're following the naming convention that we set forth for when you upload the fiber scans. But yes, if you're using a new model, you need to let us know what the model type is, so that way the team that downloads the scans from the shared folder is able to download those, because they'll have a different code they use. So that's why it's important that we know if someone's using a new machine.
All right. And then was there another comment or about the fiber scan?
This is Jen from Cincinnati again, Cara. Is there a way for us to know if it wasn't uploaded correctly? Like, as far as we know, all the ones that we've done have been uploaded correctly. If they haven't, I'd love to know that so I can correct it.
Right.
No,
Yeah.
you'll know, because they'll tell us. They'll tell us.
So there's a couple ways. There's a couple ways to know. Every month, around the middle of the month, we put up a new PSC report on the website. I encourage all of you to, it's on the secure website, I encourage all of you to go and look at it. And it includes information about how many valid fibro scans have been completed out of all of the visits. If that number doesn't look right to you, a lot of the sites do not, and I'm looking at our one that we just posted a couple days ago. A lot of the sites, we did find more of them this month. More of them got uploaded. And we made a programming change that our programmers we didn't know this at first, but we're only looking for them to match on the exact same day as the visit. But we know that you all are doing them sometimes up to 90 days after that baseline visit. So we've expanded that window. We matched some more things. Then we found out about a couple of sites using new machines, and we're able to update the coding. So we have matched a few more than we had. But for most of the sites, we still don't have a fiber scan on everyone. We might only have it on 50% of people. So the first thing I would say is, please look at those reports. Please let us know if it doesn't seem like the number that's in the numerator is right. Some sites have 0 or 1 done. I think you guys will have a gut reaction to like, no, we've done them on everyone and you're only getting them for half of them. The other thing is we do, when we run those reports, is we do run a QC, and that goes to the monitors. And the monitors should be reaching out to you and saying, hey, you filled out the liver stiffness CRF in Link, but we don't have a record for the fibro scan for you. And I think that those haven't gone out yet for this month, but will be soon. And, please work with the monitors to try to resolve those. So this can be kind of a two-way thing. We're trying to give you information, but also please look at the reports and let us know if something doesn't look right to you.
Also, would it be possible to have like a live tutorial of how the upload is done for those who've never uploaded for Force? Because I feel like I've done the upload and it's been wrong, and
Right. And I think in your case, Cynthia, the person who was uploading and who was responsible for Force no longer works there, and now who's really supposed to teach you? Was that a scenario?
Well, yes, I tried to do it myself and I still am
Right.
not getting credit for them. And so
Right.
I'm not sure what I was doing wrong. But then I've also run into the issue of this low disk space from the machine. So I haven't gotten to do it again. But if we can just do like a quick live tutorial to like refresh our memory or just make sure we're
Mm-hmm.
doing it exactly how you want us to
Mm-hmm.
upload, I think
So
would be
Cynthia,
helpful.
Cynthia, were you given the force move by chance?
No, I was not.
Okay, so we'll make sure you get the force move because that may help you as well, and we'll try to set something up. I myself, I'm not too keen on the process. I don't know about the process, but I know Melissa is like the queen of the force study. So, but we'll send you the manual of operations, and that should have instructions on how to upload to the folder.
And do you have the link to upload to SharePoint?
Yes,
She
I
should have
highly
access to Melissa. Yeah,
yes.
yeah,
I
I
just
do
wanted to
remember
clarify.
getting her. Yep.
Yeah, I can, if anybody wants to know, yeah, I can give a quick demonstration on how to upload to SharePoint. So,
Yes,
Perfect.
please.
Thank you, Melissa. Okay, I guess we need to do that then. Okay, great. Okay.
that on the call.
Okay. Great discussion. Next slide. I don't think we need to go over this too much. The radiologists have been real good about putting in any type of clinically significant incidental findings, and the documentation of it stays locally, either through an EPIC research encounter that you can print out and leave in your files, or some institutions have used, we sent around in the very beginning an incidental findings form that to complete, and again, just keep in your own files locally, a hard copy on site.
Yeah, we do see that when we are monitoring. We have seen that form completed by the radiologist.
Yeah, I think they're doing a good job of getting that
Yeah,
done.
yep,
Yeah,
they sure are.
yeah. And the coordinators, you guys might be asked, if you don't have the actual hard copy incidental findings form, I think, again, in Colorado, that the radiologist was putting the report in EPIC Research Encounter, but then the coordinator, the PI, somebody's got to go in there and print it out. So just so you know, that's the other place it might be. Okay. Next. Oh, that was it. Yeah, the only other thing that was brought up at our recent leadership meeting for this study is the 6-month and 1-year follow-ups. So a lot of the sites now have a few kids who should have been seen at 6 months, summer of 2022, or 1 year right about now. And it's not happening. And so we want to know what's going on there. What are the barriers to getting these kids back in for the 6-month or 1-year follow-up?
Hi, this is Siri from LA. So I have one patient that one patient that missed their 6 months follow-up simply because the child got tested positive for COVID, and then once that was cleared, he was positive for RSV. So the parents did not feel comfortable enough to bring the patient to the clinic.
Okay.
But we are rescheduled to have him come in March to complete the 1-year follow-up.
Okay. Yeah. How about others? Are patients all of a sudden not interested, or you can't get a hold of them?
Cora, this is Jen from Cincinnati again. We had one that was scheduled to come in during their 6-month window. He canceled his appointment. He rescheduled it for outside of his window. I tried emailing him and said, hey, could we at least get some of these CRFs done, if nothing else? I got no response. Texted him, I got no response. So we're just going to have to do the 6-month window as missed, or it could be like 6 weeks out of window when he comes in May. It's very frustrating.
So he'll get his 1-year one. Yeah. And I mean, all you guys can do is try, right? To get them to come to those 6-month ones. And if it's clear that, especially the older teenagers, if they're just not doing it, it's just going to be missingness of data, but you can't force them. And it is important to get that 1-year visit. Very important.
Yeah.
That's when your
Yeah,
MRI
I
is
think,
getting.
yeah, and I think Jen, that was way above and beyond. So I appreciate your efforts to
Yeah.
contact that participant to get them in. I mean, there's only so much you can do, and you guys are doing your best. So, and that's all
Yeah.
we ask. So
All
yeah.
right. Well, thank you guys. I will
Well,
exit.
thank you, Carla. We appreciate your time.
Yep, and I thank all the coordinators for all your hard work. We got 70 plus that are enrolled, so we're getting there.
Yeah, we are.
All right, see ya.
Okay, great. Thanks
Bye.
again. Okay.
Thank you so much.